So my name is Eric Ladera, and I'm joined on the chat by my colleague Tao Bui. We will be we're going to have a wonderful guest presenters today from NYC Reach, which I'll be introducing in just a moment. Some housekeeping. We're going to be removing all of the lines. In the meantime, if you have any questions, please ask your questions over the chat feature. You can also raise your hand, and we'll respond to you. At the end, we'll open up the lines again for a question and answer session. If you have any questions.
The conference has been muted.
So this is the first of a three-part webinar series called Tools of the Trade that is specifically about electronic medical records. The first part will be about implementing medical records, which is actually not yesterday, which is today, the 4th, September 4th. Part 2 will be lessons learned by implementing electronic medical records, and in this case, we're going to be speaking to folks in organizations that have experienced interesting challenges or have had interesting experiences with their own electronic medical records. And so that's going to be more of a best practices. And the third one is going to be scheduled for sometime in the first week of October, and that will be on continuous quality control. Or CQI, I'm sorry. And so that one will be a little bit more about the monitoring and evaluation using electronic medical records. So to begin, I would like to start with a poll, and I would like to get opinions from you guys to understand a little bit about how you feel about medical records. So the question that I have for you here is, currently, electronic health records are blank from my organization. Please choose an answer now. All right, we have a few responses, and we'll go ahead and get to the results. So as you see, most people on the line think that medical records feel that medical records are important for their organization or a driving force. But we have a few that consider them to be attained. And we hope to be able to answer some of these questions today that we might be able to facilitate this and make this easier for you guys, but also so we could all learn a little bit more about this. I'm going to start with some background as to why we sponsored this series. The Affordable Care Act and the National HIV/AIDS Strategy has created some major changes in the field, and this is also goes along with the CDC's high impact prevention. The frameworks for the National HIV Strategy leverages federal and private resources to reduce HIV incidence, to increase access to care, to improve health outcomes, and to reduce HIV-related disparities. Along with the Affordable Care Act, they have an unprecedented opportunity to be able to improve access for HIV care and develop more sustainable funding streams, and to be able to expand effectively HIV care, the model developed by Ryan White. The essential components for the Ryan White effective HIV care model allows us to be able to help the chronically ill HIV patient from many different angles. So the goals of the managed care to be able to help control the virus, to be able to improve the immune system, the status of the immune system, to be able to help give the patient a near normal life expectancy, and to be able to enhance their quality of life. Additionally, it's also very important to be able to prevent HIV transmission, to be able to help prevent the other chronic illnesses within the patient. So the goals of this could be achieved by using the medical home model and provide access to primary and specialty care that is coordinated and monitored by the HIV primary care team, also by psychosocial social workers, and to be able to help understand their needs. The cornerstone of this is the electronic health record, and the electronic health record is really where the services all come together, and they all collaborate. Everybody who has access to the electronic health record, medical services that are used for patients with complex needs to prevent the barriers and the gaps. So that might be the understanding where the patient is as far as adherence, as far as how they manage their lives outside of the clinic, to be able to manage not just their HIV, but manage their ability to be able to adhere to the services that and the medications that they need. And all of this is located all in one central system, which we call the electronic health record. The electronic health record is shared by the entire team and is a key component to these integrated models. So that's what brings us here today. We're here to talk about the electronic health record and how the electronic health records are used to be able to put all of this together and create this one-stop service. So I'd like to introduce our special guest today. We have Victoria Pascal. She's an outreach specialist for NYC REACH, the New York City Regional Electronic Adoption Center for Health. Coming from a health service research background, Victoria currently works with healthcare providers in all 5 New York boroughs to help them select the electronic health record system, implementing it in their practice, and it tests for meaningful use and incentive programs. Joining her today is the Community Initiatives Coordinator on the Community Engagement Team at the Primary Care Information Project, Tori Foster. She specializes on using health information technology in community-based environments. This includes integrating community-based referrals into certified electronic health records and designing a dashboard to track blood pressure in faith-based organizations. So I'd like to welcome Victoria and Tori to the line right now. Thank you.
Thank you so much, Eric. It's really great to be on the call today. We're excited to learn more about what you all are doing and to explain a little bit about what we do here at NYC REACH and at the Primary Care Information Project. So we'll go ahead and get started with our slides. Awesome. So my name is Victoria Pasco. As Eric said, I'm the outreach specialist for NYC REACH. NYC REACH is part of the Primary Care Information Project, which is housed within the New York City Department of Health and Mental Hygiene. And our mission here is to really use the latest technology to give doctors tools to better prevent disease and improve public health outcomes. PCIP was actually the model for the National Regional Extension Center program, and we were the model behind that, which now we have 62 regional extension centers nationwide, and we're the regional extension center for New York City. The program allowed us to extend our network throughout the boroughs, and we have over 9,000 providers in our network. And this graphic just kind of shows our footprint in those boroughs. You can go ahead to the next slide. A little bit about the regional extension centers. The RECs represent a real range of organizations that serve local communities throughout the country. And the REC's focus is to provide on-the-ground assistance for individual and small practices, medical practices lacking resources to implement and maintain EHRs, and then those who provide primary care services in public and critical access hospitals, community health centers, and others that serve mostly low coverage areas, people who lack adequate coverage for medical care. Like I said, I know we have a bunch of folks on the call today. We're the REC for New York City, but if you want to learn who your REC is and about the resources they can offer, you can go to healthit.gov, and the link below will lead you to a place where you can look up where your regional extension center is. You can go ahead to the next slide. So we're here today to talk about electronic medical records and how they can really help connect patients to care and improve quality of care. The main goal of Health IT is to improve the quality and safety of patient care. And really the promise of full realized electronic health record is having a single record that includes all of a patient's health information, a record that's up to date, that's complete, and that's accurate. This puts providers in a better position to work with their patients to make the best informed decisions about their health. Some of the most obvious benefits of an EHR are that they improve quality and convenience of patient care, they increase patient participation in their care, improved accuracy and diagnosis of health outcomes, improved care coordination, which is going to be huge for the CBO perspective, and then finally increasing practice efficiencies and cost savings. Some additional benefits is that an EHR is more beneficial than paper records because it really does allow providers to track data over time and to identify patients who are due for preventative visits and screenings. It also allows providers to monitor how patients measure up to certain parameters, such as vaccinations and blood pressure readings. And it really does improve overall quality of care at a practice. The information stored in an EHR is not easily shared with providers outside of a practice, so a patient record might even have to be printed out and delivered by mail or specialist or other member of the care team to ensure that the information is shared with the appropriate people. So next slide. Healthcare really is a team effort. Shared information really does support that effort, and that's kind of the guiding force between what we do at PCIP. When all team members can communicate with each other effectively and efficiently, everyone benefits, patients, their families, and providers as well. So the nation's health and economy benefits from using this and being coordinated in general. Electronic health record adoption requires investment of time and money. And it really is, we realize it's not a magic bullet, it's a tool. The benefits really do outweigh the costs, and the financial incentives are one way to help providers make this transition, and that's where NYC REACH comes in with the Meaningful Use Incentive Program. The ERA Act authorized the Center for Medicaid and Medicare Services to offer financial incentives for physicians and for hospital providers who demonstrate that they're meaningfully using their electronic health record. That means that they haven't just enacted it in their practice, they haven't just implemented, but they're using it in a very thoughtful and well-planned way to really improve the quality and safety and efficiency while also reducing health disparities in their practice. And meaningful use is here to help incentivize that process and to really make sure that providers are making good on using that record in the best way possible. Because better healthcare does not solely come from adopting technology itself, but through the exchange and use of that information to best inform clinical decisions at the point of care, meaningful use is here to encourage that process. So far, payments totaling $7.1 billion have already been issued to professionals and hospitals by CMS, and an estimated $22.5 billion will be paid from 2011 to 2022 to eligible providers to adopt an EHR technology. So a lot of providers are already taking advantage of these incentive programs, and there's a lot more money on the table to help make this transition a little bit more smoothly, especially for providers that are in a resource, struggling with resources to make these changes. So next slide. more on the meaningful use pillars, you can see that really improving patient care and reducing health disparities is the guiding light. So NYC REACH, along with the other regional extension centers around the country, is currently subsidized to assist Medicare and Medicaid primary care providers and Medicaid specialists with the Meaningful Use Incentive Program. To become a meaningful user of your electronic health record, you must meet a set of measures that illustrate that you're using it in a way that exemplifies the pillars that are listed. Success not only will help ensure that your practice is improving patient care, but it will also make sure that you're eligible for incentives. Up to $63,750 for Medicaid and up to $39,000 for Medicare. Providers seeing Medicare patients, it's important to note that penalties for not meeting meaningful use begin in 2015. So that'll be 1% in 2015, 2% in 2016, and so on. NYC REACH is subsidized along with the other regional extension centers throughout the country to make sure that we get jump-started on this and to help providers get the ball rolling to attest for these programs. So we encourage folks to get started as soon as possible to really take advantage of this money while it's still available and to make sure you avoid these penalties. So you can jump to the next slide. This diagram lays out which healthcare providers are eligible for the Meaningful Use Incentive Programs. There are providers that are just eligible for either the Medicare program or the Medicaid program, and then there is a group of providers that could be eligible for either or. This kind of lists that out for you. Most frequently at NYC REACH, because we work with a lot of primary care providers, we work with a lot of MDs, a lot of nurse practitioners, and certified nurse midwives as well. So this list can be a helpful way of seeing where you might fall in terms of your organization. And you can use this tool from CMS, the link is at the top, to help determine your eligibility. So next slide. Just a quick overview of the meaningful use measures. The meaningful use objective measures are divided into a core set and a menu set. The core set has 15 measures. Providers must achieve all 15. And the menu set has 10 measures, of which they can choose 5. And then of those menus, you have to choose at least one public health measure. Those really depend on the practice. You can choose or use any measure that really applies to what you do in your setting. And there's a lot of flexibility within them, but the core set all providers need to meet. If you want more information on the meaningful use measures, you can go to healthit.gov or nycreach.org, and you can get more information about the specific measures themselves. As a part of the core set, providers will also be required to report on clinical quality measures to CMS, and there's more information about those as well. So we'll go on and move forward to the next slide and start talking about something that I spend a lot of time working with providers with in the New York City area, which is the vendor selection process. It can be a little bit daunting for people starting out. With over 2,000 EHRs certified for meaningful use, choosing one can seem really overwhelming, but that's why we've developed so many resources to help providers find the right EHR for their practice. We realize that there really is no one-size-fits-all EHR, and only you and your colleagues can decide which solution is best for your practice or organization through planning and careful consideration. It takes a lot of dedication and some time, but we like to look at it as kind of a 5-step continuum, starting with defining your needs and the criteria you want out of your EHR, then narrowing down your choices, actively shopping by doing vendor demos, and then comparing and evaluating those different vendor experiences that you've had against each other to finally choose the right EHR for your organization. You can go to the next slide. Each practice or organization has unique needs, so it's important to evaluate the specific needs of your practice when starting out this process. From initial appointment setting through treatment and diagnosis of the patient and all the steps in between, taking an objective look at the workflow of your practice or organization is crucial. It's also really important to remember that when going through this process, you really want to get all of your team members around at the same table, making sure that everyone is on the same page, that front office staff, that administrators, that the providers themselves are all really working together to explain what the needs are in terms of what they do on a day-to-day basis, so that you can compare and make sure that you really are getting a system that encompasses everyone's role. Analyzing your workflow can start with just looking at efficiencies and difficulties that you've been having, figuring out how an EHR can help you with practice management, and really increase your practice's efficiency, accuracy, and improve quality of care. So next slide. The vendor selection worksheet that we've developed here can be a really helpful tool in the process. While you're shopping around for the right system, you can keep track of the different features of each one and then do a side-by-side comparison to help you make your final decision. If anybody would like a copy of this, you can reach out to me directly and we can get you set up so that you can use this in your initial shopping around. Next slide. Some other things to include are to really look at the company integrity of the system that you want to adopt, making sure that you can trust the vendor that you select and making sure that it's certified by the office, the ONC. You can get more information about the certification from healthit.gov, but most of the systems that we work with are continuing to go through the certification process, and so we're sure that they have everything they need in order to be used meaningfully. You also want to look at the cost and benefit, the look and feel, and the different features and functions of the system to make sure that they suit the needs of your particular organization. And like I said before, for larger organizations, that might mean getting people together and forming some sort of an EHR selection or implementation committee or task force with representatives from each department to make sure that all the needs and views and ideas are being represented in the process. For smaller organizations or practices, that can just mean convening a once-a-week meeting with people who have kind of key stakeholders in your practice to make sure that everyone's up to date in the process. So the next step, we'll go ahead and look at cost considerations. There are a lot of different costs associated with adoption, and that's part of the reason that all this incentive money is out there to help cover those costs. One thing to be mindful of is that costs come with, first of all, implementing and then also staying on and maintaining on your system. So you need to make sure that you're taking all of these into account. This is a roundup of some of the different costs associated with EHR implementation at your practice. While the cost for each of these items will vary widely from practice to practice and EHR to EHR, the basic framework of cost is all about the same. So in planning to adopt an EHR, it's important to remember that the cost will not just be EHR licensing, but it also include IT support, training, and interfaces with labs and billing clearinghouses. So this is a good way, and especially using the chart that we showed you earlier, the vendor comparison chart, it's a good way to look at your budget beforehand rather than being surprised by unforeseen costs later. Next slide. As we utilize more and more technology, it becomes really apparent that we need to protect the information that's considered private. In order to meet meaningful use, a thorough risk assessment must be conducted at least once a year to ensure that you're adequately protecting your patient information. Small practice providers aiming to achieve meaningful use must conduct that it's called a risk assessment or risk analysis of their certified EHR technology. And some of the things that come in with this are making sure that your equipment is stored correctly, that office security procedures and workflows are in place, making sure that privacy protocols and administrative safeguards are also in place, and then also having a plan for disaster preparedness. At NYC REACH, we were on the ground for Sandy and working with a lot of providers during the hurricane and afterwards to make sure that they were protecting their patient information. We actually had a lot of providers sign up after the hurricane because they lost a lot of their records. One provider out in the Rockaways was actually very resourceful in taking all of his records, and they got wet in the hurricane, so he froze them in a giant walk-in freezer so that he could keep that information, and then later he used it to put it into his new EHR system so he didn't lose all of his patient information. So having an EHR and being really planned and careful about how you run your practice and set it up can really help ensure that you are activating and making sure to be true to your patients by making sure you're representing the best practices on securing your patient health information and avoiding any breaches. And at NYC REACH, we help guide our members through conducting a thorough risk analysis and risk management plan for their practice or organization, and we help them avoid security breaches and implement health information technology best practices. So next slide. A little bit more about what we do at NYC Reach. We have free on-site support for primary care providers and Medicaid specialists, and Medicare providers can take advantage of our group seminars, events, webinars, and online tools. Like I said before, we do a lot with vendor selection. We also have a lot of meaningful use support, billing and coding optimization, and the list goes on. We have an extensive online resource library, and we have a lot of seminars and webinars that cover new deadlines, new information, new best practices, all of that. And all of the different regional extension centers have similar resources. So once again, if you're not in the area, you can absolutely benefit from your regional extension center's resources. So next slide. Oh, next slide. Thank you. If you have any questions about NYC Reach, actually, can you go back one slide? There we go. If you have any questions about joining NYC Reach, you can feel free to contact me, Victoria Pasco. My email and phone number are below, so be sure to take that down. We have a free membership, once again, for all of the providers that I mentioned earlier, and we can help get you in touch with the correct regional extension center if you're having an issue finding the resources in your area. Our website is www.nycreach.org. Tons and tons of great resources there for organizations and for practices that are just going through this process, or for those that have been on an EHR for some time. We'd love to help you in your search and connect you to resources if we can. So the next slide. We have a lot of great community resources as well. As a member, we're the only regional extension center that's a part of the health department. So we have a lot of great resources to community programs. And we've been working with a lot of different initiatives to find out and to really pilot how EHRs can be used as a tool to refer patients to programs that can help keep them healthy. We can provide and list community health resources and train staff to implement alerts that will flag eligible patients. And we have a lot of great resources for ACOs and for patient-centered medical home practices as well. So at this point, I will turn it over to my colleague, Tori Foster. She works on a project called the South Bronx Community Referral Task Force, which is a really interesting example of how CBOs can use electronic health records to really improve quality of care and community relationships. So thanks so much for your time. I'll turn it over to Tori.
Hello, everybody. Next slide, please. So originally, we came up, I'm on the community engagement team, and it's hard to think about how technology relates to CBOs. So we came up with this vision statement. The South Bronx Community Referral Task Force seeks to ensure that South Bronx physicians are knowledgeable about community resources for healthy living and have the necessary tools to effectively refer their patients into these services and programs. So to that end, we asked a group of physicians to apply to be part of the task force, and then we just basically went out and interviewed these physicians about what they were doing currently for community referrals and what they would like to see happen. Next slide. So this is very, very valuable because the first thing we found out is that many of the physicians we're working with didn't know about community resources. They don't live in the South Bronx, and they sort of drive in every day and assume that it's this wasteland of nothingness that has no resources to offer, which is definitely not true. The second thing is that most providers are incredibly strapped for time. So in terms of making community resources, they definitely feel that it's important and they would like some help supporting their patients to do things like lose weight or quit smoking. But it's just they don't have the time. So it was really important to try to figure out a way to streamline referrals to community-based organizations into the workflow that was already in place for the provider, so it wasn't something that takes extra time. Another thing that they said is that feedback is desirable. A lot of times, they felt like referring to a community-based organization meant that they were sending their patients off into outer space and they had no idea, what was happening after they gave the referral? Did the patients even show up? If they showed up, did they have, a successful experience? Were they able to make some progress with their health? And in general, and this is probably true all over the city, it's very hard to get patients to take action and access these resources. Next slide. So we knew that there had been some successful collaborations in the past. Urban Health had done something called Adopt a Shop, where they're working with a shop that's geographically close to them. And they basically can give their patients vouchers to go to this specific shop and get discounts on healthy foods. Montefiore has been working with the YMCA Diabetes Prevention Program, and they've made at this point it's actually over 1,000 referrals into the YMCA Diabetes Prevention Program. And Essen Medical partners with senior centers to coordinate for their very high-need senior patients. So we knew that it was possible, so we took a look at these previously existing community-based resources and tried to, develop something with the wisdom that was imparted to us from these resources. Next slide, please. So what we ended up doing was selecting five practices that have the eClinical Works, which is the EHR that the Department of Health in general supports. And we had some great stories. Uptown Medical Associates has engaged her office staff to refer people into the diabetes prevention program. And they've been able to do it using their already in place referral system that they've been using to make clinical referrals. So they have a referral specialist that counsels the patient and submits the paperwork. It's the doctor who really IDs the patient, but after that, it's just a referral specialist who does everything else. So it's not taking away from the face time the doctor gets with the patient. They have the office manager, Iris Marti, and she deserves a mention because she is really a force of nature, who just oversees the workflow, represents them at our task force meetings, and she's just really on the ball. She knows how to work their EHR really well. She understands what's happening within the practice. And actually at this point, there are probably over 30 referrals have gone to the YMCA's Diabetes Prevention Program. Next slide. So before we thank you, the question is how we do this. And we basically take a look. We basically add referrals as a part of the clinical workflow in the EHR. This means that we've developed a system of registry alerts that pop up when a patient is eligible for referral to a certain CBO. And this is pretty convenient because the provider no longer has to think about remembering, A, that this program exists, B, that whether or not a patient is eligible for the program. So for the YMCA's Diabetes Prevention Program, the patient has to have a BMI of over 25. And so these alerts pop up for patients that have BMIs over 25. And then on top of that, the referral form is embedded into the alert, so the practice can print the form on the spot, get the patient to consent into the program, and fax the form right off. So they don't have to have a file or a secret drawer somewhere where these referral forms are hiding. And so I would say that is really the biggest thing here. If you guys want providers referring into your programs, it's really important to make sure it's as easy for the provider as possible. And we believe that using the EHR is a really wonderful way to do that. Thank you very much.
Thank you guys so much. Thanks for that presentation. We have some questions. We have a question for medical for our participants right now, and partly to understand how people feel about patient confidentiality when it comes to electronic health records. The question is, patient confidentiality is either improved by electronic health records, more vulnerable with electronic health records, not as important as quality of care, or it's just not my job. Please select. And afterwards, we're going to open up the lines and for some questions and answers. All right, so most believe that it's improved, and some believe that it is more vulnerable with electronic health records. And we'll also have those on the line who just say it's just not their job. We'd like to pose this question to our presenters. Is confidentiality improved or more vulnerable with electronic health records?
Confidentiality is something that we get a lot of questions about. Personally, I work with a lot of psych professionals who are worried a lot about their patient records because they don't want information about their patients being leaked in any way that could negatively affect them. But that's definitely a concern for all providers. We found that through an EHR, you can really maintain access to who's seeing information. I think that there are a lot of overlaps with HIPAA to make sure that all information is covered, that it's protected appropriately, and that's where that risk assessment and privacy and security information that I related earlier comes in. As a part of meaningful use, risk assessment and privacy and security is a cornerstone of that because you need to make sure that your patient information is encrypted and safe on the web. And we have a lot of ways of ensuring that, and all of the certified vendors have a lot of ways to protect PHI, patient health information, that I think that you can't achieve with paper records. You're a lot less vulnerable to, well, first of all, like I said before, losing your information in some sort of a disaster or a natural emergency. So on our end, we think that patient confidentiality is much improved, and you can also find that with the use of a patient portal, patients are within a lot more control of their patient data because they can actually access their test results, they can access information about their health, and have more ownership over that. So while some people might worry that having a patient portal could decrease your patient confidentiality, we would argue that it really encourages patient engagement and that it really is a repository of all of your patient data in a safe place. That is, obviously assuming that you're taking care to make sure that you have a secure network and that you're doing all the important things you need to avoid a breach. And that's why the regional extension centers have a lot of information about privacy and security and making sure that you can attain it at your practice. So that's about all the info we have on that. But if there are any specific questions, feel free to let me know.
Well, I would say in terms of
The conference has been muted.
Sorry about
The
that.
conference has been unmuted.
I would say that in terms of the community referrals, there still needs to be a paper component because patients have to consent into the program with their signature. However, the providers can then scan the referral form back into the EHR, which actually is much more confidential than having a referral form lying around with information about a patient's diabetes.
Thank you. And so the lines are now unmuted to have some for anybody who would like to ask live questions. And I'd actually like to start because I'm really, Tara and I have been speaking a lot about the project that you were just referring to in the Bronx story. Yep. And one of the questions that I have is, so Montefiore is a big hospital, and there were a lot of other smaller community-based organizations. How did you get the buy-in from the smaller community-based organizations to be able to network with a larger hospital?
So actually, we focused very much on small practices just because we wanted a variety of environments to test this in. And Montefiore has developed their own electronic system. They're pretty on top of that stuff. So we found that in lots of cases, it's really the smaller practices who needed the support to do something like this. They don't have like an IT team or anything like that. So it was just helpful to have me coming out and customizing these alerts in the first place, because they don't necessarily have a person dedicated to looking after their EHR or have time to be inventive about what they're doing with their EHR. Another thing is that actually in some ways it's been easier to roll out in small practices because it does require a small change in workflow. I mean, and that small practices just tend to be more nimble with that stuff. They don't have to educate, everybody within an environment that, or they don't have multiple sites. Things like that make this sort of a program much more complicated. I think you have a bigger yield with big practices, but with small practices you can get it off the ground much more quickly.
Excellent, thank you. I'd like to, all the lines are unmuted right now. If somebody would like to ask a live question of our guests.
That was excellent.
Okay. Would you like me to transfer you to Regina? She's actually not. Okay, hold on one moment.
I think we're getting some background noise. Does anybody have any questions of our guests?
No?
Well, thank you. I have we have a question from the chat line. What tools are available in electronic health records to increase patient education?
Do you want to take it, Tori?
Well, so I think it really depends on the software you're using. But there are a couple places in eClinicalWorks where you can embed patient education. You could make these registry alerts I'm talking about and attach some forms to them. So if it's like the appropriate, let's say you want to talk to a patient about hypertension and you had some sort of a paper-based form, you could attach a PDF to their record that would pop up. It depends what you mean by patient education.
And on our end, I've seen a lot of examples of how the patient portal has been used to improve patient education. So if a provider has a patient come in that does have diabetes, it makes follow-up a lot easier if you can send references or materials or websites or any information like that about the education you're looking to give that patient to their direct patient portal or to their email address as opposed to trying to mail it. We found a lot of success in distributing that kind of information that way.
Great, thank you. We also have a comment that people of our, we think the presentation was clear and clear and practical. We really appreciate your time here. Also, is there anything, afterwards we're going to have an evaluation form if you would like for us to forward your information to NYC Reach, please fill out the evaluation form and include what contact you would like to be reached with. Is there any other questions right now on the line? Well, if there's no other questions, on behalf of Tara and myself, we'd want to thank all of you for joining us today for this webinar. We'll have another webinar in approximately 2 weeks, and everybody who's registered for this one will get an invitation to that one as well. We want to send a very special thank you to Victoria Pascoe and Tori Foster for an excellent presentation today, and we thank you so much for spending the afternoon with us.
Thanks so much. It was a pleasure.
Thank you. Please stand by.